Olá, gostaria de agradecer a sua Black e a World Ceratocone Society. A gente está aqui no Congresso Mundial de Ceratocone, o primeiro Congresso Mundial de Ceratocone, uma das pessoas mais importantes do Congresso, o professor Theo Seiler, que veio de Zurique para cá para prestigiar o Congresso e realmente aumentar o nível científico. E a gente vai estar fazendo algumas perguntas para o professor Seiler sobre crosslinking, uma vez que ele, juntamente com o grupo, desde Dresden, quando ele ainda estava na Alemanha, começaram os estudos sobre crosslinking no mundo e realmente revolucionou a terapêutica do ceratocone. So thank you very much, Professor Seiler.
It's a pleasure.
Welcome to Brazil, welcome to Ouro Preto. And my first question is that you could summarize the development of crosslinking. Tell us about the story on the dentist, how you developed that, and that's going to be very interesting for us to hear about that again.
I mean, that was an easy story. I was with the dentist and he just filled in some holes, and after he had done his job, he just used his ultraviolet light and shined into my mouth. So I was asking, hey, what are you doing there? And he said, oh, I'm hardening it now. And it took a week until it came to my mind that hardening could also be done in the cornea, the keratoconus cornea, which is needed. And so I came to my staff when I was chief of the Department of Ophthalmology in Dresden, and with Pearl we sat together and looked for ways how we could harden the cornea. We could cross-link the cornea. And it was very clear from the beginning that we would have to look for methods which are not harmful to the cornea at all, because we do have other methods to do cross-linking with butaldehyde, Karnofsky solutions, so with chemical ways, aldehydes to do that, but those are usually very invasive, and so we look for ways to cross-link the cornea in a less harmful way. One was riboflavin and ultraviolet, and the other one was, of course, glucose. Glucose is producing cross-linking in tissues, and so we did our first studies just using glucose solution, and indeed we had 4 times hardening of the cornea. However, it took 20 days, and so that was not a good clinical solution. And then, of course, then was the ultraviolet light, which has to be enhanced by photoreactivation. And we used then riboflavin because it's a non-toxic substance. It's natural vitamin inside the body anyway. It cannot be toxic in that way. And so we followed a lot of animal experiments and in vitro experiments to find out the right concentration to get an optimal effect.
Great. And the first results you published the follow-up of a long term. What were the main benefits that the patients had with the cross-linking treatment?
Well, that was only one main effect of cross-linking. That was stabilization of the cornea. And in prospective studies, it turned out that in 97% of the cases we had an effect that there was no further progression of the keratoconus anymore. So that low failure rate, which is obviously less than the FDA requirement regarding failures, is for the cross-linking essential, because you can promise the patient that the Damocles sword over his head, that the keratoconus is going on and going on and going on, that will be stopped.
So in your practice, understanding that the cross-linking procedure will just stop progression of keratoconus and decrease a little bit the level of irregularity?
Let's say it that way. I mean, we do have 37% of the patients who show a significant regression of the keratoconus, going along with the regularization of the cornea. But that's something you cannot promise your patients. You can promise the patient that the keratoconus is stopped and there will no further development of keratoconus going on. But the regularization, which is a nice side effect, is something that you cannot anticipate.
So in your practice today, which patients you indicate cross-linking? You prefer to do it in a very early disease or in late disease?
Oh, that is very easily decided. I mean, since we know that we can prevent only progression, we should do it as early as possible. So that's number one. And the second thing is, that is also the indication. I mean, if I have a patient with a progressive keratoconus, I first have to document the progression, of course, within 1 month, 3 months, 6 months, whenever. It's a slow progression or it's a fast progression. But once the progression is documented by subsequent pentacams or topographies, then, of course, we are doing it right away. And I do not look at the age of a patient. So we're doing this in children up to 10 years. It's a little bit difficult, but starting at 10 years, I'm doing it without hesitation anymore. And regarding guys older than 50 or 60 years, who just have to document progression, it's rare that we do have regression in those cases anymore. But even then, I would not hesitate to do the cross-linking.
Great. And in the patients that are not only progressing, but they already had a lot of irregularities, how you approach the patient to improve vision as well?
I mean, this is a totally different story. Cross-linking can stop the progression, but then once you have stopped the progression of cross-linking, you still have to select means for visual rehabilitation. That means we can regularize the cornea with the surface ablation, which is rather a fine-tuning instrument. You get better optics by using rings. High myopia can be treated by phakic IOLs. And of course, there are other means than to intraocular clear lens exchange, whenever it's depending on the age, of course. But visual rehabilitation is something that has to be added and can be done in one session. For example, once I'm removing the epithelium for cross-linking, I certainly would think of doing a surface ablation if indicated. Once I'm doing the surgery regarding cross-linking, I also could slip in 2 rings to regularize the cornea. But nevertheless, the cross-linking's job is to stop the progression and to create a stable situation in the cornea. But visual rehabilitation is a different question.
So looking at the cross-linking and keratoconus progression, I ask you in 2 situations. First, the patient is a female patient, a young female patient that has keratoconus that decided to get pregnant. Will you indicate for her to do cross-linking before getting pregnant, or if she doesn't know she's pregnant now and you see the progression during pregnancy, you approach the cross-linking during pregnancy?
When during pregnancy, you shouldn't do any intervention at all. It's just a safety issue. But if she is coming in and say, listen, I married last month and I'm going to be pregnant during the next year, I would ask her to delay the pregnancy until we have done the cross-linking, because we know that there's a certain amount of female patients during pregnancy, they develop real evolutions, strong evolutions of keratoconus, which only in a few patients is reversible after pregnancy. And so I would do the cross-linking right away as soon as possible, and then tell in both eyes, by the way, and tell then the patient that then after that time it's good to be pregnant, not before.
Good. And in the cross-linking procedure, how is your technique today? Are you removing the epithelium? How?
There are several approaches right now to save the epithelium, but none of them has been proven to be as effective as the standard way to, when you remove the epithelium, embed the cornea with riboflavin until it's saturated, the cornea is saturated, and then start the 30-minute irradiation. This is still the gold standard, and that's what I'm using in the majority of the cases. In some cases where patients are very anxious and you're not even sure that this patient really has a strong progression. It might also be a valuable option to use benzalkonium chloride 0.01% to digest the tight junctions of the epithelium, and then try to inhibit the cornea, so to a lesser degree with riboflavin, and do the cross-linking afterwards. But I mean, you always have to discuss it that this is for sure less effective. So I'm still using the standard approach, removing the epithelium and let the patient suffer.
Yeah, a little bit. Another question. Cross-linking has done first for stopping the progression of keratoconus, but we know that we have other indications that may benefit from this treatment.
Yes.
Tell us about that, please.
One major say application of cross-linking that is coming along is the treatment of infectious keratitis. We do have a prospective multi-center study in Scandinavia going on, and Mortensen have shown at the last congress in Leipzig that every patient with a non-treated infection on, say, therapy refractory keratitis, when he did the cross-linking, the eye calmed down in every case, the infection stopped in every case, and so it seems to be a very effective treatment in patients, at least where you have no medical therapy that is working. So the second application beyond keratectasia is melting. Corneal melting is in some cases a very bad disease because you cannot stop the melting, such as morbus telea. We have no good therapy today in morbus telea. In some of the Sjögren syndrome, where you get melting of the cornea, and you have no chance to stop that. In those cases, you should try also cross-linking, because in about 14 cases of melting that we did in Zurich, we could stop the melting in every single.
Right. So, changing a little bit the topic into LASIK screening to prevent keratectasia after LASIK. What's your routine, and could you summarize your gold standard for doing this screening for patients for LASIK?
You mean to avoid or to prevent keratectasia? I mean, I'm pretty much coming along with this ectasia score from Randleman in Emory, using parameters like age and thickness of the cornea and myopia correction, the degree of myopia correction. However, what I'm really missing in that ectasia score of Randleman of the Atlanta group is that that they never looked at the posterior surface of the cornea. We all know that the epithelium of the cornea is leveling out irregularities. Dan Ranstein showed very nice maps of the epithelial thickness in keratoconus, and it turns out that over the peak of a keratoconus, the epithelium can be as thin as 25 microns, and at the fundus, at the basis of the cone, it's then 70-75 microns thick. And that means that we are missing 5 to 10 diopters in that range by just leveling out effect of the epithelium. So it's quite natural to look at the posterior surface of the cornea, where the endothelium cannot level anything out, and so that posterior float is for me a crucial thing. If I have a posterior float seen in the pentacam with a spherical approximation within 8 millimeters of more than 15 microns, I just leave my hands off. Period.
Even no PRK?
Oh, the PRK has to be discussed with the patient, and that is very much depending on the state of the patient. I mean, if it's a young lady, I rather would do the cross-linking, doing at the same time with the surface ablation. If it's a guy 28 years old, oh, say 38 years old, asking for 5 diopters of myopia correction, I would not hesitate to do a surface ablation without cross-linking, of course.
Great. And the last question goes, I cannot, we are in a cross-linking and keratoconus, that's all about it, but in going to refractive surgery, what do you think is the future of the refractive surgery on the cornea?
Oh, I truly believe that on a long-term run we will have only one laser doing the job. Most probably we will have only a femtosecond laser, which will not work in the infrared right now, but most probably we will have a wavelength in the bluish range, because the femtosecond laser in that wavelength range will be able to have a precision of less than a micron regarding cuts and reshaping of the cornea, and therefore I believe on a long-term run we will get rid of the excimer lasers and have only femtosecond lasers do the job.
That's excellent. Thank you very much.
You're welcome.
So it's a pleasure to have you here.
Oh, come on, the pleasure is quite on my side. Coming to Brazil and seeing friends and being accepted and enjoying the hospitality.
Okay, thank you very much.
Thank you very much indeed too.